Dear Good morning, dear colleagues. Welcome to this session, NTM Dialogue, Rethink NTM, entitled Who, Why, and When. My name is Gernot Rode. I'm a physician working in Germany, and I'm very happy to welcome you to this symposium. My colleagues Stefano Aliberti from Milan in Italy and Christoph Lange, also coming from Germany, the northern part of Germany, we will present to you the latest developments in NTM disease. And Stefano will start with presenting who is the NTM patient. Big problem in the clinical practice to identify the right patients. And then the next question, of course, is whom to test for the disease. Then I will focus on the therapy and why it is so challenging, and try to highlight some of the major problems in NTM management. And then Christoph will focus on the new guidelines which have just been issued, and then spend a little bit more time on the treatment of MAC disease, Mycobacterium avium complex. And please be aware of our potential conflicts of interest we have to show before every symposium. You see, all of us are also working together with the industry, which I think is a good sign if you're an active scientist in the field. So what are the objectives of this symposium in more detail? We aim to address key questions raised by clinicians. So really coming from the clinical floor regarding the management of NTM pulmonary disease. And you know that the incidence is changing. We see more and more NTM patients in the clinic, but which are the patients at risk for NTM pulmonary disease? This is one of the objectives. Then, of course, when should we test for NTM? Who should be targeted for testing? And when is testing makes testing sense? And then if we have a positive result, when and how should these patients be treated to ensure the best outcome? Not all of the patients need to be treated, but most of them, of course, need to be treated. And I think the new guidelines have clarified some of the issues, and we will discuss this at the end. And so we will have now 3 presentations in a row. And if there are any questions coming up, please use the chat function of this website. You find it on the right bottom corner. There you can type in questions, and we will collect all these questions and come back to them at the Q&A session at the end. So please use this and make this as interactive as possible. So this brings me already to the end of this short introduction, and now it's my pleasure to introduce Stefano Aliberti, a long-standing friend and also long-standing expert in the field of bronchiectasis and NTM disease, working in Milan in Italy. And Stefano, it's now my pleasure to introduce your talk, Who is the NTM patient?
So thank you very much, Gernot. It's my pleasure to discuss with you the characteristics of a patient with non-tuberculous mycobacteria. And I would like to share with you a very important message at the beginning. We do not have one single Mr. NTM patient. So I would like to change a little bit the title of my presentation into Who are the NTM patients? And the reason why is because NTM lung disease is a very heterogeneous disease from different aspects. From an onset point of view, we tend to recognize a chronic or subacute onset, but we also have in mind patients with an acute onset of non-tuberculous lung disease, non-tuberculous mycobacterial lung disease. From a clinical perspective, Pulmonary signs and symptoms like cough, sputum production, or shortness of breath are there, but we also tend to recognize symptoms, systemic symptoms like weight loss or fatigue in patients who are anxious and depressed. And from a radiological point of view, we go from a trim-bud pattern to bronchiectasis to cavitating nodules or even to big cavitations. So the most important thing when we have a suspicion of a non-tuberculous mycobacterial lung disease is to investigate the patient using this balance. A balance between the exposure, risk factors for exposure to NTM and NTM species, and risk factors for local and or systemic immunodeficiency. And I would like to walk you through 3 different clinical cases that will help me in identifying specific risk factors of this balance. The first one is a case of a 62-year-old female with a 1-year history of chronic cough, fatigue, weight loss, with a low BMI 16. She was doing gardening, never a smoker, with systemic hypertension. The patient was immunocompetent, and when she underwent high-resolution CT scan because of chronic cough, cylindrical bronchiectasis in the middle lobe and lingula have been identified. The patient underwent bronchoscopy, and the Mycobacterium intracellulare was identified, sensitive to both macrolide and amikacin. Interesting things of these clinical cases are, first of all, the gender. We know that there are many studies that are reporting a higher prevalence of NTM in female, but most of these studies are coming from Japan and North America, but we recognize female gender as a possible risk factor for NTM. The onset, this is a chronic onset, and the patient underwent several pulmonary visits before a pulmonary physician thought about NTM, suggested a high-resolution CT scan, and then a bronchoscopy. We should investigate exposure because we know that NTM are widely distributed throughout the environmental and water and soil. We have data about water and soil, among the others, as a possible risk factors for NTM. And the other interesting thing is that this lady had no previous history of other respiratory or systemic disease. It's easy for you to recognize this as the so-called Lady Windermere syndrome. It's a postmenopausal female's syndrome with a patient with scoliosis or mitral valve prolapse with a low BMI, no pre-existing lung disease. They might have also trim-bud pattern without bronchiectasis, with a prolonged clinical course, cough, fatigue, weight loss, and mainly with trim-bud and bronchiectasis in the middle lobe and the lingula. The second case is a little bit different. We are talking about a 76-year-old man, ex-smoker with COPD and bronchiectasis, with a low PD1, 35% predicted, MMRC3. He is a frequent exacerbator on triple therapy. He also received azithromycin for a while in the past, and the CT scan is showing an important emphysema and a big cavity. The sputum of the patient were positive for Mycobacterium mebium. This 76-year-old man has different characteristics than the previous lady. First of all, the patient already had a structural lung disease. And this is my second important message for you today. We should always think about a possible infection of non-tuberculous mycobacteria in a patient with a chronic infection or even an acute infection of bronchiectasis, COPD, cystic fibrosis, interstitial lung disease, or primary ciliary dyskinesia. There is a strong association, as showed by Claire Andrejak and co-authors in this paper published in Thorax in 2013 on a population of Denmark people, case control study, showing a high ratio of NTM in patients with COPD, asthma, pneumoconiosis, bronchiectasis, especially bronchiectasis, and previous tuberculosis. This is the reason why most of the guidelines on bronchiectasis are suggesting a sputum mycobacterial culture for all the patients with mild, moderate, or severe disease at baseline, and repeating the investigation when the patient is deteriorating. And also CF guidelines are suggesting NTM screening every year in patients with cystic fibrosis. The patient was on tripod therapy, and we need to think about inhaled corticosteroids because we now have data on the association between inhaled corticosteroids treatment and non-tuberculous mycobacteria. Patients on current ICS use, especially if high dose of inhaled corticosteroids are used, and there are some differences that might be present according to the molecule used, becomethasone versus budesonide versus fluticasone. Macrolide is not a risk factor for NTM, but I would like to spend a few minutes to remind you the importance of screening for non-tuberculous mycobacteria, all the patients we want to put on long-term macrolide, because long-term single treatment with a macrolide in a patient who might have NTM is very dangerous because resistances might occur. And what we don't want is to have a macrolide-resistant NTM to treat. The first two cases remind us patients we have in clinic who are apparently immunocompetent, but they have host factors, structural lung damage that are risk factors for NTM lung disease. I don't have time to talk about potentially deleterious polymorphisms who are associated to NTM like CFTR, although this is a very interesting field. In the clinic, we might also have immunocompromised patients with a lung disease. And I'm not talking about AIDS with disseminating NTM disease, but I'm talking about patients with primary or secondary immunodeficiencies, patients that are immunosuppressed because they are under biological drugs, chemotherapy, or patients with strong connective tissue disease, or even patients who have been transplanted. So I would like to conclude my presentation with this last clinical case of a 46-year-old man with cystic fibrosis who have been always negative during the NTM screening before he underwent bilateral lung transplantation. He was put on immunosuppressive therapy with corticosteroids, tacrolimus, and MPA. And after lung transplantation, all the NTM screening were also negative. At some point, after 2 years, the patient experienced a rejection, ACR grade 2, underwent pulse steroids without signs and symptoms, and after 2 weeks, he experienced a sort of bronchitis treated with ciprofloxacin, and the patient underwent a CT scan showing opacity in the lung. The bronchoscopy done identified a Mycobacterium xenopi that had been treated, and the patient underwent treatment. Key messages of this clinical case are, first of all, remember that in patients with chronic lung disease like CF, but also like bronchiectasis or even asthma, sinus disease is very important as a reservoir not only for bacteria, but also for mycobacteria infection. The patient was an immunosuppressed patient under steroids, tacrolimus, MPA, and the screening for NTM was very, very important in these patients, although at the beginning was negative. So we identified the use of pulse steroids as a possible trigger for NTM infection. The patient has a very atypical clinical and radiological manifestation, as we might have in immunocompromised patients. The patient at the beginning had no signs and symptoms, and the chest CT scan show several opacities. So it's important to remember that we might have a different clinical and radiological manifestation according to the level and the type of immunosuppression. My take-home messages are, first, as I said at the beginning, There is no just one Mr. NTM, and this, I think, is the most difficult challenge we have so far. We should always put NTM in our differential diagnosis in front of a patient with a chronic but also acute respiratory infection. And in order to have a high suspicion of NTM, we should always ask the right questions in terms of exposure and in terms of investigating local or systemic immunodeficiencies. This suspicion is important to guide the indication and the intensity of a workup that might go from NTM culture of sputum to bronchoscopy, even to lung biopsy. And this is the reason why regular screening is suggesting for some patients group, like those with CF and bronchiectasis, but we should also think to regular screen our COPD or asthma or interstitial lung disease patients according to their clinical status, the immune status, and their exposure to potential exposure to non-tuberculous mycobacteria. With this, I would like to thank you so much for your attention.
Thank you, Stefano. So now let's have a look at the challenges of the therapy and the reasons for that, particularly the role of macrophages and the biofilm. We know that NTM are common in diverse organisms. They are ubiquitous in the environment, and we find them in soil and in water, and more than 180 species have been identified. But they're also very diverse because they are not all causing disease in the same way. The virulence is different. Some are very, very virulent. Others are nearly not virulent at all. And also the response to treatment is very different. And related to this, also the development of antibiotic resistance. Unfortunately, we have very limited understanding of the different species. And although there is an increase in the prevalence, still the understanding and management of NTM relates only to few of all the known species. So let's have a look at the different species. And we have this nice study from the Netherlands, published in 2009, which has looked at, in a big center, looked at all the different NTM detections and then related this to the clinical picture, and using the ATS criteria, then looked how often the detection also was related to disease. Then you see, for example, Gordone is the classical example of a mycobacterium which is nearly never related to disease or causing disease. The same is true for Fortuitum and Chelone probably. But then we have, on the other hand, Avium, Abscessus, and others, which often cause disease. So here clearly you see the difference in virulence. And we have, in our center in Maastricht at the time, also made a similar analysis and also noted the frequencies. And you see that Mycobacterium avium is by far the most frequent one, when we also found a little bit the same spectrum of virulence as Jacob von Ingen's group did in Nijmegen. And then you see Kansazi plays an important role, Gordone plays an important role, MAC unspecified, and intracellular, but then you also see others which are seldomly found and also do then very often not cause disease. If we look at the European situation, we have data from the NTM net, and these are many samples that have been summarized here in this analysis, and I'm just showing you some examples from the European centers. You see that Germany has MAC by far is the most common species. This is also in France and Italy and in Spain, very important. A little bit less so in the UK, where, for example, rapid growing mycobacteria are much more often found. So clearly geographical differences which we have to take into account. But now let's look at the pathophysiology and the reasons why the treatment is so difficult. And this is because after the uptake of the NTM by inhalation route, they are propagated into the distal airways and the alveoli, where on the one hand they attach to the mucosa and also penetrate the mucosal barrier, but they are also phagocytosed by macrophages, and they can survive actually in these macrophages, and in the long term also can accumulate in biofilms. So after the uptake of the macrophages, they invade the macrophages, and there they use multiple pathways, but in the end they can also survive within the macrophages and reproduce. And this is possible because they reduce the phagosome-lysosome fusion. They are taking up in the phagosome, and then usually the lysosome fuses to the phagosome and kills the pathogens, but they can actually inhibit that. They also can reprogram the cell metabolism to enhance the expression of NTM-related genes, and this helps with replication, and also leads to a reduction in the normal macrophage function. So they survive in the macrophages, they reproduce there, and then if they're ready, then they drive them into apoptosis, then they are being released, and they are ready to infect other bacteria or survive in the biofilm. So this is a vicious cycle of the infection, and we look at the timing aspects here, you see that after 2 days after uptake, which usually takes just some minutes, less than an hour, then they do what I have told you. They survive and reproduce within the macrophages. And after 48 hours, so after 2 days, they drive the macrophages into apoptosis and then are released and can infect other cells. So clearly, when within the macrophages, it is difficult for antibiotics to reach them, because they also can hide from the treatment action within these cells. But also the accumulation of biofilms makes antibiotic treatment more challenging. And this clearly relates to the clinic. And if we look at the treatment series, we see that up to 60% of patients are actually refractory and do not convert with oral guideline-based treatment. And on the other hand, only 16% of patients with refractory MAC disease have in the end a favorable outcome with oral antibiotics. And this is regardless of the treatment regimen selected. So looking a little bit more in detail at these figures, nearly 12% have, after the termination of the final treatment success, and 4% of those who have to be treated longer, and in the longer run also show treatment success. So you see many people have treatment failure, they die during treatment, or have an unfavorable response. So another important issue is the risk of macrolide resistance, which clearly complicates therapy. If we look at the mortality of MAC pulmonary disease, the 5-year mortality is 27%. But in patients with macrolide resistance, this increases to 47% at 5 years. So you clearly see that this is determining mortality is the macrolide resistance. And what are now the predictors for this resistance? And of course, always with antibiotic resistance, the previous long-term combination macrolide therapy can be a risk factor, particularly because it's often used for alveolar or intracellular infection. Then in inappropriate initial therapy drives resistance, which is also a general theme in the development of antibiotic resistance. And if ethambutol is not given in the early combination therapy, this has also been identified as a risk factor. On the other hand, which is an important problem, is the macrolide monotherapy, which is recommended for patients with bronchiectasis or COPD to prevent exacerbations. You know that this treatment is given, and after the publications in the New England Journal was quite popular. And often all the precautions that were necessary if you want to prescribe such a treatment were not taken. So, for example, you have to rule out NTM disease in these patients before you give this long-term treatment, and this has often been not done. And often during the ongoing treatment, you should check whether patients have NTM treatment, because we have these diagnostic problems. So vigilance is here very important. And particularly if you're treating patients with BU or COPD before initiating macrolide treatment, always think about NTM. And this is particularly challenging because they are also a risk group to develop NTM. So treating MAC challenges are multiple. So we have the late diagnosis. This is due to non-specific symptoms which may overlap with the underlying lung disease, and also the fact that 2/3 of the patients who are diagnosed already have moderate to severe disease. So early diagnosis is very rare in the clinics. Then we have the therapeutic challenges. We need to convince the patients to take a multi-drug treatment for 1 to 2 years in general. There's a risk of side effects, which often makes the treatment difficult in practice. And then, of course, if you can't adhere to the, let's say, most common protocol, you need to know what other choices do I have. And so clearly, treatment failure is an issue, and we have little data on the efficacy of other drugs. So this is really the reason why these patients should be in the hands of experts which have a lot of experience with the disease, and then have also already have choices for alternative treatments. And of course, the adherence to the evidence-based treatment guidelines is poor. We know this, and also this needs a good expert who can have a firm lead on the treatment together with the patient in order to really carry out good treatment in order to reduce antibiotic resistance. So in summary, we have learned that NTM are common, they are diverse, and MAC is clearly the most common pathogen in Europe. It is difficult to treat as a result of 2 factors. One is, of course, the bacterium itself, and on the other hand, the patient. We have learned about the sequestration of macrophages and in macrophages, and the accumulation into biofilms, and both, of course, are poorly penetrated by many antibiotics. So this is an extra challenge we have to acknowledge. We have talked about the delayed diagnosis or the wrong diagnosis often in the beginning. Then we have acknowledged the fact that there is a high level of macrolide monotherapy in the community for the underlying condition, which increases actually the risk of resistance development. And of course, we have a high risk of oral guideline-based treatment failure, for which then other options are very limited. This is the end of my presentation. Thank you very much for listening, and I'm happy to take questions and to pose or ask questions. Please send these questions through the platform so that we can pick them up and answer them later. Thank you very much. Now it's my pleasure to introduce Christoph Lange, who's talking about the new NTM guidelines and how they relate to MAC disease.
Thank you very much, Gernot. I will now present the new guidelines for the management of patients with a MAC pulmonary disease. The last international guideline for the management of patients with non-tuberculous mycobacteria was issued by the American Thoracic Society and the Infectious Disease Society of America in 2007. And it took 13 years to issue new guidelines for the management of non-tuberculous mycobacteria pulmonary disease, which are now issued by the American Societies for Pulmonary Diseases and for Infectious Diseases, and the European Societies for Pulmonary Diseases and Infectious Diseases, which are the European Respiratory Society and the European Society for Clinical Microbiology and Infectious Diseases. Now, how do these guidelines differ from the 2007 guidelines? First of all, we have more international societies on board. Secondly, these are the first guidelines that are evidence-based. Thirdly, there are 22 defined PICO questions that are being addressed. And fourth, these guidelines are only focused on the 4 clinically most important species. The definition of non-tuberculous mycobacteria disease has not changed in the 2020 guidelines compared to the 2007 guidelines. It is still based on clinical symptoms and radiologically documented pathology on the presence of 2 consecutively positive samples for the presence of mycobacteria from sputum and also on the exclusion of other pathology. Physicians often hesitate whether to treat patients who have pulmonary pathology documented on imaging and have findings of mycobacteria from bronchopulmonary specimens. Reasons to wait could be patients are very old or that patients cannot provide consent for being treated, or there is threat of drug-drug interactions, like in patients who receive other immunosuppressive drugs, or that drug susceptibility testing for those mycobacteria are not present yet. There's strong evidence that when the definition for non-tuberculous mycobacteria are met, physicians should consider to initiate treatment for non-tuberculous mycobacteria disease, especially in patients where acid-fast bacilli are seen on sputum smear microscopy, and especially when there is severe disease, for example, cavitary lung disease. It is also very important that drug susceptibility testing for the key drugs, the macrolides, and also for aminoglycosides are being performed in the microbiology lab. In the clinical spectrum of disease, there are 2 different forms. One is a nodular bronchiectatic form that we see here on the top picture, and the second one is a fibrocavitary disease that we see on the bottom picture, which is the more severe form of the disease. Some patients can have both characteristics. It is important to perform CT scans, not only X-rays, to determine these forms of disease and the extent of disease. Treatment is based on macrolides. And in addition to the macrolides, ethambutol plus a third drug, which is usually rifampicin. Patients who have macrolide-resistant Mycobacterium avium pulmonary disease have worse treatment outcomes than those who have macrolide-susceptible disease. And among the macrolides that are available, azithromycin should be the preferred macrolide for the treatment. It is well tolerated, it is easily dosed as a once daily dose, and it has the best tissue penetration among the macrolides that are available on the market. There's a clinical question whether patients can be safely managed with 2 drugs or they should receive a 3-drug regimen. And there's evidence to support a 3-drug regimen throughout the therapy over a 2-drug regimen. Also, patients who have extensive disease, like fibrocavitary disease, and also very extensive nodular bronchiectatic disease, they benefit from an initial addition of IV aminoglycosides, IV amikacin, or streptomycin. These patients have to be monitored carefully for adverse events that regularly occur when aminoglycosides are being given IV for longer periods of time, especially ototoxicity and nephrotoxicity. Patients who receive Additionally, IV aminoglycosides in severe forms of MAC pulmonary disease significantly have better results in terms of culture conversion than those who are treated with oral triple therapy alone. In patients who have nodular bronchiectatic disease that is not extensive, an intermittent therapy 3 times weekly may be sufficient, whereas patients with more severe disease, especially those who have fibrocavitary disease that is macrolide susceptible, should be treated with a 3-drug macrolide-based treatment regimen on a daily basis. When patients do not achieve culture conversion on a 6-month treatment of a guideline-based therapy, they should receive amikacin liposomal inhaled suspension in addition to the oral guideline-based therapy. This results in significantly better treatment outcomes. Patients who fail therapy after 6 months of the guideline-based treatment, who receive amikacin liposomal inhalative suspensions, have a 3-fold increase of the percentage of culture conversion, and 63% of those patients who converted stayed or remained converted on treatment. And this effect lasted for at least 3 months beyond the end of treatment after 12 months. Treatment with amikacin inhalative liposomal suspension is related to a high rate of adverse events, especially dysphonia, cough, and bronchospasm, also musculoskeletal pain, whereas other adverse events were not increased in those who received inhalative amikacin suspension in addition to the oral guideline-based therapy. With the best treatment available at present, we are not able to achieve sustained culture conversion in more than 2/3 of the patient. But to achieve this, patients should receive at least 12 months of therapy beyond the time of culture conversion. When compared treatment regimen of more than 12 months versus less than 12 months were compared to each other, those that received treatment for more than 12 months had significantly better culture conversion than in the other group. In summary, the new guidelines issued that refine treatment for MAC pulmonary disease that allows physicians to follow patients from the diagnosis of non-tuberculous mycobacteria and to the treatment of refractory disease. Key points in these new guidelines that is issued by 4 international societies is that when definitions for MAC pulmonary disease are present, patients should receive treatment. Treatment should be based on at least 3 drugs, with azithromycin as the most important component. In addition, ethambutol plus a 3rd drug, which usually is rifampicin. If there is severe disease, for example, severe fibrocavitary disease or with a lot of acid-fast bacilli seen on sputum smear microscopy, IV aminoglycosides should be used in the initial phase of therapy, but this treatment should be monitored very closely for the occurrence of adverse events, especially ototoxicity. When patients do not achieve culture conversion within 6 months of a guideline-based oral treatment regimen, this is defined as therapeutic failure, and then patients should receive amikacin liposomal inhalative suspension, which significantly improves treatment outcome. All patients should receive at least 12 months of therapy beyond the point of culture conversion. And it is especially important to think about non-tuberculous mycobacteria, pulmonary disease, to test for non-tuberculous mycobacteria, and to initiate treatment for non-tuberculous mycobacteria disease. And I thank you very much for your attention.
Thank you. Thank you, Christoph. Now it's time for our Q&A session, and we had many questions coming in. So the first questions, I think, are for Stefano. Stefano, there was a question: which patients with which structural lung diseases do you think should be screened for NTM? Which ones are the ones that you have mentioned in your talk, and do you have some more from your clinical background?
Thank you, Gernot, and thank you for the colleague who asked this question. So, according to the available data and evidence and guidelines, I think that patients with cystic fibrosis should be screened for non-tuberculous mycobacteria. We have several data, and we have also guidelines recommendations. The second population is non-cystic fibrosis bronchiectasis. We have several data coming mainly from registries worldwide, and we also have recommendation from international guidelines. There are some guidelines who are suggesting regular screening for non-tuberculous mycobacteria in bronchiectasis, while some other guidelines are suggesting to look for NTM in specific clinical or radiological characteristics. In my clinical practice, we are screening for NTM all our bronchiectasis patients. And then we might want to screen also patients with other chronic lung disease. The data on COPD and asthma or interstitial lung disease are less than what we have in CF and bronchiectasis, but we now have high-resolution CT scan. We have some clinical data that might suggest an infection of NTM in these patients. So I would suggest also a screening for NTM in these patients, at least for severe patients and those who are frequent exacerbators.
Thank you, Stefano. So let's focus on the COPD patients a little bit more, because we know that patients with advanced COPD, they have a higher risk, and then many of those who have frequent exacerbations actually receive macrolide treatment to prevent exacerbations. So what is your concrete advice? When should you test these patients? Before the initiation of the macrolides, during, after 6 months, after 12 months, and so on? So could you give very concrete advice?
Sure. So Gernot, I think that any patient who is about to start long-term macrolide treatment, regardless the chronic lung disease this patient has, and I mean bronchiectasis, COPD, asthma, cystic fibrosis, should be tested repeatedly for non-tuberculous mycobacteria. And I would also suggest to talk to the microbiological lab and start a very strong relation with the lab in order to be sure that they are looking in the proper way to the non-tuberculous mycobacteria. Because what we do not want is to have an NTM lung disease due to a macrolide-resistant non-tuberculous mycobacteria. And also, during macrolide treatment, we screen patients for NTM because this is very important. So I would say any patient who is about to start a macrolide long-term treatment.
Okay, thank you very much. There was one last question I have for you regarding your presentation, because this patient who had Pseudomonas was Pseudomonas positive and NTM. Was that at the same time? And what treatment implications does this really have?
Yeah, so the question is about a patient with cystic fibrosis. And let me tell you this. This patient was an adult patient. We don't have clear data about co-infection of Pseudomonas and NTM in the adult population. Most of the data are in a mixed population of children and adults. And we have also contrasting data. I remember a study published in the early 2000s, I think 2003, from the US. Was a multi-center study who said that patient with NTM positive sputum culture had a less Pseudomonas chronic infection. But then we have some other data coming from Europe showing that the coexistence of Pseudomonas and NTM in CF actually is high. So we don't have definitive data on this, but both pathogens are clearly recognized pathogen in the CF adult population, and they deserve a specific screening and treatment. And this is what we are doing also in our adult CF center.
Thank you. Christoph, there was a question, because when we talk about co-infections, do you also see co-infections of tuberculosis and NTM disease in the same patient?
This happens, but it is rare. We sometimes see also different NTM species in a same patient. And then it's difficult to find or to design the right treatment, because it's unclear which one is actually the causative pathogen. This is the same situation if there is co-infection of, for example, Mycobacterium avium and Mycobacterium tuberculosis, where the design of a treatment regimen then will require adding more drugs if we want to address both pathogens adequately. This is a rare situation, but it happens.
And so in terms of treatment, which pathogen do you focus, and what do you also have experience on the eradication of these coexisting two pathogens?
Yeah. So if there is, for example, well, first of all, usually the laboratory gives information that they grow bacterium A and bacterium B, let's say Mycobacterium tuberculosis and Mycobacterium avium. The finding of Mycobacterium tuberculosis should always prompt treatment for TB. Therefore, standard treatment for tuberculosis in the absence of antimicrobial therapy would be then the first step in designing a treatment regimen. In case of Mycobacterium avium, one would then search or be more sure that this organism plays a role in disease if there is repeated isolation of the non-tuberculous mycobacterium in addition to the TB bacterium. So we would first wait for additional cultures, and as these organisms are much faster growing as compared to Mycobacterium tuberculosis, we can also then rely on the experience that we will get those cultures if the bacterium is there and has a causative role. We would then add to the quadruple therapy with rifampicin and isoniazid and pyrazinamide and ethambutol only a macrolide, because we already have 2 of the 3 drugs that would be required for a standard treatment regimen against Mycobacterium avium. We have to be a bit careful as the macrolides and rifampicin are inducing the same enzyme system that is metabolizing these drugs. So therapeutic drug monitoring, meaning assessing drug levels of these agents, would be wise if we use them in parallel.
And thank you. There were many questions, of course, also focusing on the new inhaled medication, the liposomal amikacin solution. So one question was for me about the toxicity, and I think we all expect that these inhaled antibiotics have much less toxicity, but still there is some systemic uptake. But case like the one we have just discussed, Christoph, when would you then also introduce in such a co-infected patient additional inhaled antibiotics?
So the guidelines are pretty clear about the recommendation for using amikacin liposomal inhaled suspension. And this is in patients who have treatment failure, and treatment failure is defined as those who have a guideline based treatment regimen for at least 6 months and still have positive cultures. This is not so unusual in Mycobacterium avium infection, for example. The bigger problem is that once patients get on treatment, physicians do not do regular cultures. And one of the problems is that patients with non-tuberculous mycobacteria tend to have little productive cough, and that many of them say that they cannot produce sputum to get the cultures. But much more efforts need to be done to get regular monitoring of the effect of treatment, for example, by standardized microbacterial culturing every month on treatment. And if there is still, apart from a positive culture, also smear microscopy positivity, this would be an indication to add the inhaled liposomal amikacin suspension after 6 months. Treatment outcomes, as far as we know at present, is much better. And of course, one can ask, could that not be added in the beginning of the treatment if in those who fail treatment, monotherapy makes a difference? And this is, as far as I know, currently being addressed in additional trials where treatment with inhaled liposomal amikacin has also been investigated as frontline agents for these diseases.
Right. Talking about, let's say, newer approaches to therapy, what about the other new TB drugs like bedequalin? Do you see a role for that in NTM disease?
In general, no. There is little evidence that they are very effectively. There's, for example, a case series in patients with Mycobacterium abscessus disease where patients have been treated on a bedaquiline-containing regimen, and it's a handful of patients, less than 10. The majority achieved culture conversion, but also the majority then had reversion after culture conversion, so it was not a sustained effect. Very rarely, in really selected circumstances where we do not have any additional drugs for patients with Mycobacterium abscessus disease, we have used bedaquiline as part of a treatment regimen, and in those patients, the treatment was actually in the end successful, but they received 5 other drugs, and it's difficult to say in these also only handful patients which of the drugs and which combination has been the game changer. From what we know from the microbiological data, the diaryloquinoline bedaquiline is not very effective in NTM disease.
Thank you very much, Christoph. Stefano, we also had some questions focusing on the immunosuppressed patients. Can you tell us a little bit more about NTM disease in immunosuppressed patients?
Sure, Gernot. So the scenario of immunosuppressed patients with an NTM lung disease radically changed over the past few decades. In the mid 80s and 90s, most of the patients with NTM were immunosuppressed, were patients with AIDS and HIV, and the clinical manifestation of these patients was of a disseminating NTM disease with a really poor outcomes. The kind of immunosuppressed patients we are seeing now is a little bit different. So we are not, as a pulmonologist, we are not seeing a lot of AIDS patients with NTM. Mostly, we see patients with an heterogeneity of immunosuppressions, mainly due to cancer, immunosuppressive therapy, anti-TNF-alpha therapy, biological therapy, who might have not a disseminating disease, but a lung disease due to NTM. So this question is very important because as a pulmonologist, we often are consulted in these patients, hematological patients or patients under immunosuppressive therapy. And we tend to also look for NTM patients, not only if they have a chronic infection, but also in patients with an acute infection, with an acute lower respiratory tract infection. All these patients might deserve a special treatment. And the last point I would like to make is we need to think about NTM also if patients who are about to start an immunosuppressive therapy are sent to us for consultation. This is not always is the case, but we should think about this because some of these patients might deserve a special NTM treatment before or during immunosuppressive therapy.
Thank you. Yeah, that is a very important point. Coming back to the NTM screening of the patients, how far should we go? I mean, is just sputum enough, or do we need repetitive sputum 3, 4, 5 times, or do we then have to switch to bronchoscopy? So what is the practical approach in patients where you suspect NTM disease or you really want to rule it out, but it's difficult to obtain samples?
Perhaps I can help to address that. In contrast to tuberculosis, the border between disease and not disease is much more blurry in NTM infection. And you've shown this nice slide from Jakob van Ingen that, for example, in Mycobacterium gordonii, you hardly ever have any disease, although it's the third most isolated mycobacterium at our National Reference Center here in Borstel. Whereas in Mycobacterium kansasii, you almost always have disease and it behaves like Mycobacterium tuberculosis. And as a general rule of thumb, in addition to the definition for what is disease and what is not disease, which has not changed in the new guidelines versus 2007, quantity of the organism. So if you see acid-fast bacilli on sputum smear microscopy, that is more an indication to initiate treatment. Therefore, monitoring of sputum, if patients produce sputum, would be mandatory. Repeated isolation will also put you more to the decision to treat than a single isolate. The site of the origin of the specimen, a sputum has not the same quality as, for example, a pleural effusion or any other sample from a sterile site. Then we already talked about the species. Kansasii would be almost mandatory to treat, whereas Godone would also be mandatory not to treat. And then the host risk factors play a role.
Okay, thank you very much, Christoph. I see the time is nearly up, so we have such an exciting Q&A. So I just want to remind all of those whose questions were not answered to join our discussion in the breakout session, which you can access through the Insmed industry page. Thank you very much for listening, and have a great Congress Day today.